Good afternoon, everyone. I would like to remind everyone that our meetings are web streamed and televised. For those in attendance, I would ask that you ensure your phones are on silent mode. We are lucky to have Bill Jackson joining us today as the camera volunteer. Thank you, Bill. We are beginning today with the Board of Health, as this is the first board meeting of the year. Members are required to take their oath of office. Prior to that, I would mention that when we meet as the Board of Health, I am the chair and you are the members. So we avoid the terminology of mayor and councillor under these proceedings. Also, directly after this meeting, we can proceed into council. Members, if you will please stand, the clerk will lead you in your oath of office. The agenda, I guess I can hold on that point.
All right, if you will all repeat after me, and no shenanigans when I say state your name. There's always a Weisenheimer. I state your name.
Crystal Chop.
Do solemnly swear.
Do solemnly swear.
That I will be loyal to Her Majesty the Queen.
I will be loyal to Her Majesty the Queen.
And to Canada.
And to Canada.
And that I will uphold the Constitution of Canada.
And that I will uphold the Constitution of Canada.
And that I will, to the best of my ability.
And that I will, to the best of my ability.
Discharge my duties as a member of the Haldeman Norfolk Board of Health.
Discharge my duties to the Haldeman Norfolk Board of Health.
Faithfully, impartially, and according to the Health Promotion and Protection Act.
Faithfully, impartially, and according to the Health Promotion and Protection Act.
Municipal Conflict of Interest Act, and any other act, regulation, rule, or bylaw.
Municipal Conflict of Interest Act and any other act, regulation, rule, or bylaw.
All right, thank you. And if you could sign them, I'll come around and sign and collect them right now.
Thanks. Okay, the agenda is before you. The confirming bylaw was omitted, so I have a motion to approve the agenda with this addition. The motion reads that the agenda be approved with the addition of the confirming bylaw 19-01. It was moved by Member Rabbits and seconded by Member Geisens. All in favor? And that's carried. Are there any declarations of pecuniary interest? Seeing none, we will proceed. Marlene, I will hand it over to you for the Board of Health orientation.
Thank you, Board Chair Chops, and good afternoon, Board Chair and Board members. As you know, my name is Marlene Miranda, the General Manager of Health and Social Services and the Chief Nursing Officer for Public Health. It is my privilege today to welcome you to your first Board of Health meeting as our new board. Today, my colleagues and I are providing a high-level orientation of public health and will continue to provide ongoing orientation of public health services, programs, and provincial requirements throughout the year with reports at the monthly Board of Health meetings. We ask that you hold your questions to the end, and as we provide packages to you, we ask that you allow us to walk you through them. If you have a pressing question throughout the presentation, by all means, though, please do ask. Today, I am pleased to introduce my colleagues, Dr. Shankar Nesithuri, our Acting Medical Officer of Health, Mr. Shamir Okoronkwo, our Director of Quality, Planning, Accountability, and Performance, our Manager of Health Protection, Mrs. Stephanie Pongratz, and our Manager of Health Promotion, Mr. Syed Shah. As your leadership team, we are here to provide public health expertise to support your unique role as a board member to make informed decision-making to promote and protect health in our communities. The Association of Public Health Agencies, also known as ALPHA, is a not-for-profit organization that provides leadership and services to public health, at which the board is a member. The orientation manual that was circulated to the board members, which is this document here, has been provided as a reference document that we encourage you to read to understand the requirements and compliances of the Board of Health. So what is public health? Public health is defined as the organized effort to keep people healthy and prevent injury, illness, oops. Sorry, I'm clicking more than I should here. Sorry about that. So I'll start again. Public health is defined as the organized effort to keep people healthy and prevent injury, illness, and premature death. It is a combination of programs, services, and policies to protect all Canadians. It's also defined as the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. Public health differs from the healthcare system as the focus is on the community health, not the individual. Public health goes back as early as 1833. With the first Public Health Act enacted being enacted in 1873, with several amendments over a century, and with the first Board of Health actually came into fruition in 1882. The current act, known as the Health Protection and Promotion Act, was proclaimed first in 1984. In the past decade, a significant amount of enhancements to support the act have been realized with a focus on standardization and more recently in the last few years on accountability. The Haldimand Norfolk Health Unit is one of 35 health units across the province with several different governance structures. With the dissolution of the former regional municipality of Haldimand Norfolk in January 2001, Norfolk County was delegated to administer the Board of Health for both Haldimand and Norfolk. This is important as the decisions you make around this table for the health of the community are decisions for both the counties of Haldimand and Norfolk. To enable Haldimand to have a voice, the Health and Social Services Advisory Committee was struck, which is comprised of 3 council members of Norfolk and 3 council members from Haldimand, to review the reports that are brought before the board and to influence the decision provided and a recommendation to the board. Public health delivers many services and programs that are provided by a team of professional staff. The teams represent 2 sides of the public health coin of health protection and health promotion. All of these people indirectly report to the board to support the mission and the mandate prescribed by legislation. Foundationally, the QPAP team, or the team led by Mr. Okoronkwo, supports the health unit and the other departments within the Health and Social Services divisions by enhancing quality, planning, performance, and accountability. The public health is governed by statute and regulations. I have provided a package for you with the many documents that govern our practices. So, that's this document, then this is the key document. Oh, sorry. The Health Protection and Promotion Act, so we've actually printed a copy of the Act for your reference, and that's before you, is actually the most important legislation as it enables the board's existence, its structures, governance, and functions, and outlines the authority of the Medical Officer of Health. It governs nearly all of the activities of the Board of Health. That is only the beginning. Additionally, we are governed by the Ontario Public Health Standards, which is the next package that we've also provided for you. And it is comprised of actually 3 core elements. The first one is the foundational and program standards, which are the minimum menu of services the board is mandated to provide. The directives for accountability is a secondary component, and the Public Health Accountability Framework demonstrates the value for money and consists of an annual accountability agreement that is signed by the board. The third is the transparency aspect, which is encouraged to openly share the activities within the community of public health. Further to that, the OPHS, or the standards, are further supported by protocol guidelines and documents, toolkits that the public health staff use to implement effective prevention and promotion programs locally. I didn't give you a copy of that because there's actually 3 binders. So those are the protocols and guidelines that guide our programming on a day-to-day basis. I didn't think you'd want to read all of that. It's important for you to be aware of that in 2018, so last year, we saw the modernization of all of the standards and its many associated protocols and guidelines. The standards have been enhanced with additional service provisions, increased accountability, and reporting without any additional funding to our budgets. We are working to address these new directives. Further to that, there are other significant relevant laws that also pertain to public health, and the boards need to be knowledgeable about the duties and responsibilities as specified in these other laws. And this is a list of them. It's not all inclusive, but it is the bulk of the legislation that we adhere to. So as a member of the Board of Health, you have a key role to play in keeping your community health, which in turn contributes to the health of the entire community. If you look at this slide, which was pulled from the standards, the Board of Health has many different responsibilities, including continuous quality improvement, compliance, financial management, performance improvement, and monitoring and reporting. One of the most fundamental responsibilities of the board is setting the strategic plan. That is the local roadmap for 5 years. We currently have a strategic plan, which is this document before you. And in the next year, we will be engaging with the board and the community to set the next cycle for 2021. Every board must have a full-time medical officer of health. Your medical officer of health is the health authority for all programs and services. So the funding. So how do we fund all of the services of public health? This gets really complicated. So I'm going to try to walk you through it, and you'll hear more next week as we go through the levy budget. But under Section 72 of the HPPA, or the Act, the municipalities with the health unit states that the municipalities with the health unit are solely responsible for the costs of delivering public health programs locally. That said, however, under Section 76 of the same Act, it further states that the minister may make grants for the purposes of the Act on which conditions as he or she considers appropriate. This enables the province to provide funding for programs and services, and the province has traditionally done so, but is not obligated to do so. As an example, in 1998, the province transferred all of the funding to the municipality, but has since returned to the 75-25% cost share that today serves most of our programs. The Haldeman Norfolk Health Unit also receives other envelopes from different ministries and other branches. The program grace grants are the largest envelope of funding and can be broken down into 4 components prescribed in the accountability agreement with the Board of Health. The first component is the core base funding, and it is cost shared at 75-25 split, which includes most of the programs and services that allows for some flexibility in the funding envelopes. This funding envelope is over $4 million of provincial funding and includes programs such as infectious disease, school health, immunizations, just to name a few. The next two buckets of funding are program-based programs, which are cost-shared and/or can be funded up to 100%. Some of the programs within these buckets of funding are your small drinking water systems, your vector-borne programs, and Healthy Smiles Ontario. These program envelopes are very specific to the program, and there's little flexibility within these buckets of funding. The fourth component of funding is grant requests, and it's the final envelope, and we are able to put in one-time funding on an annual basis, and they typically are for 1 year time span. So the core of public health is funded by the Ministry of Health and Long-Term Care, but we are funded through other ministries as well. Through the Ministry of Long-Term Care and Ministry of Health and Long-Term Care, through a different branch, the Primary Health Care branch, we are also funded for a nurse practitioner in sexual health for approximately $110,000. Further to that, through the Ministry of Children, Community, and Social Services, they fund our Healthy Babies, Healthy Children, and it can be up to 100% to a capped amount. And further to that, they also fund our preschool speech and language programs, which can also be up to 100%, which are capped. Cost sharing with Haldimand. With the dissolution of the region of Haldimand-Norfolk, the province set a cost-sharing method for the counties initially based on population statistics, and then staff further agreed that the cost-sharing would actually be on household counts. The cost-sharing for Haldimand's contribution for the levy impact is approximately a 40-60 split. So there's a lot of cost sharing between the province and Haldimand, so I thought it would be best just to give you a simple example, hopefully to try to explain or walk you through what that looks like. So to help illustrate the cost sharing of both of those funding cost sharings, let's pretend we had a program that cost $1,000 and is cost shared with the province at a 75-25 split. That leaves a levy impact of $25,000. With the additional Haldimand cost share of approximately 40%, or $10,000, the Norfolk levy impact of a $100,000 program would be $15,000.
The native reserves, how does that portion, since we don't have any reserves in Norfolk, I've signed a number of documents related to that so far. I'm just wondering how that works out. Do they assume 100% of the cost? Do you want to speak to it,
Through the chair to Mayor Chop, well, I guess you are the chair, aren't you? I would have to get back to you with the details of that question. I know we spoke about that once before. However, I'd have to confirm with some staff that specialize in the funding.
That'd be great if we could get that material, particularly before the budget time. I just, for myself personally, since we don't have any, I understand the cost sharing, but if we don't have any reserves here, given that there's some special items that are going there, my question is whether or not that should be a responsibility that falls fully to Haldimand.
If I may, from what I recall, I believe we are the administrator of sending those funds to the reserves, and that there's no direct cost to the county, but I'll definitely confirm that.
And if I could just add on to that further, would also be, I've signed a number of documents, so there is an administrative component to that and so on. So if we could also look into if there's a charge that's being put forward to them. Thank you.
So as shared, the funding and budgeting is a hodgepodge of complexity with very specific program funding envelopes. Further to that, the funding is inflexible from one funding envelope to the other. So I have another example just to help simplify it. Under the Smoke-Free Ontario funding, it is actually in three specific envelopes of coordination, enforcement, and youth engagement. If we are overspent in enforcement and have a surplus in youth engagement, we are unable to shift the funds and must return the surplus to the province and offset the over expenditure by the levy. The board should be aware that the ministry implemented a new funding formula back in 2015 to realign the funding across what was then the 36 health units. The Haldeman Norfolk Health Unit has been at a 0% increase in base funding since 2015, with a small exception of increased funding last year in 2018. This has led to the erosion of the total funding envelope, and many Board of Healths across our province are contributing more than the 25% to offset the shortfall. With the modernization of the standards in 2018, the ministry implemented the submission of the annual service plan as the process for budgeting and approval. The annual service plan provides the ministry with a community profile, a summary of all of the programs and services, the budget submission for that year, and an opportunity to apply for one-time grants. This year, there is an opportunity to request 5 grants for the base envelope and 10 grants for the one-time funding. Staff are actively finalizing the submission for February for the 2019 budget year, which is, as you may notice, after the approval of the Board of Health budget next week, and we often do not receive the final ministry approval for the budget until the fall of that year. For the better part of the year, we are working without an approved budget and managing that budget. The last topic I wish to share with you today is the health audit, an example of compliance with our provincial partners. In the fall of 2015, the Haldeman Norfolk Health Unit participated in an audit to assess the compliance, what were then the standards of Ontario Public Health Organizational Standards and the Public Health Accountability Agreement. This audit was for the period of 2013 and 2014. The final report comprised of 48 recommendations that we are in the final stages of completion. One of the outstanding recommendations was the comprehensive Board of Health orientation, which today puts us closer to closing the loop on that final recommendation. Another recommendation that is awaiting the final step of minister approval is the formal appointment of our acting medical officer of health, Dr. Shankar Nisathure. The Haldeman Norfolk Health Unit, up until this point, as recently as October, has shared a medical officer of health with Brantford for years. And with that, I'd like to hand it over to my colleague, Dr. Nisathure.
I'm Shankar Nisathure, and I'm pleased to serve as the Acting Medical Officer of Health. Board of Health members, Board Chair, Ms. Chop, we really appreciate the opportunity today to discuss the programs and services that the Public Health Service provides the County of Norfolk and the counties of Haldeman. Can I get the slide before? Yeah, sure. Yeah, I would ask that you wait till the right time to open those boxes. But I work as a doctor, and I know human nature a little bit. So we wanted to make this more exciting than a standard talk, my colleagues and I. Is there a last slide available? The slide before it? So I included this slide for a particular reason. First of all, I'm delighted to come here and speak to you today. It may not be well known that, in fact, that the County of Norfolk and the County of Haldimand have been providing public health services for 3/4 of a century. In fact, public health services predates organized medicine or organized public health care. And that was partly because counties wanted to organize activities that kept the population safe. When we think back to the turn of the 20th century, people were dying of infectious diseases. If you think of the first public hospitals, there were sanatoriums. So we've been in the enterprise of providing public health services for a long time. I wanted to show you this photo because on the left is Dr. Demeter. He was the last full-time medical officer of health. And then he's succeeded by Dr. Locke, who is here on a part-time basis. And subsequent to that is Dr. Urbanki, who was my immediate predecessor. I think it's important to know that both Dr. Locke and Dr. Urbanki are still available to us, and I do speak to them on occasion to help us with continuity of our service. If you could go to the next slide. So I want to share with you, and this I think is a really important point, the public health service works quietly in the background. And you probably know the public health service is working when you hear little about us. And that is one of our goals, is to try to remain in the background but yet achieve our goals. There are 4 important constructs in providing public health services. That's to be discreet, confidential, strategic, and as you might find, it's interdependent. So with that, I would ask you to open the boxes. So this is something that actually happens every day in the public health service, and I'll share with you how many times it happens in a few minutes. So this is a fax from the public health laboratory in Toronto. This is a mock person, so there's no confidentiality issues. But if you go to the second page, and this is a fax that we get at the public health unit on a regular basis, faxes like this. The second page talks about, and if you look there down at the bottom, it says chlamydia detected, gonorrhea detected. So this may not be known by people in the lay community, but in Ontario, by statute, anytime you get a laboratory or go to your doctor and get a lab test, if the positive result is a result of public health significance, so diseases and conditions that the Minister of Health and the province believe are of public health significance, a copy of that report comes to the public health unit. And then we have a team to try to manage that. So in a case like this, which is a real case, which is a real happening, whenever we get presented with a disease of public health significance, we have to contact the person and be sure that they got treatment. And we have to do that discreetly. We're not here to embarrass anybody. We're not here to cause unnecessary angst. But we have to contact the person and be sure that they're actually getting treatment. We also have to contact the contacts, the people who have, in this particular case, chlamydia and gonorrhea are sexually transmitted illnesses. There are other diseases which aren't sexually transmitted. We have to get the names of the contacts, and we have to get that in a non-judgmental way, because our goal in the public health service is not to pass judgment. It's primarily to protect the public health. And so we do that every day. I want you to open the items in the blue pencil case. You know, at the onset, I can share with you, working as a doctor, we have to deal with uncomfortable things. And I have 3 children, and I grew up in a pretty traditional home. But a lot of the problems we deal with are real problems. And I want to share with you that, you know, chlamydia, gonorrhea are sexually transmitted illnesses. And what do we do at the public health unit, not only to try to help the person affected, but to help the broader community? Well, the first thing is this document. And this is a document that we do hand out. And it talks about sexually transmitted illnesses and how they can be transmitted and how they can be prevented. I've included here condoms. You know, we give out tens of thousands of condoms. We try to distribute them because we want people to be aware of sexual health. And for people who have other ways of not getting access to contraceptive services, we provide contraceptive services. This is a package of birth control pills. The issue at hand in the public health service is that it's not just about dealing with the problem immediately, but it's trying to prevent the problems from becoming more and more significant. So, how many contacts do we interact with? Well, if you look at all sexual health services, including contraceptive services, advising people about pregnancy, inquiries, tracing contacts, I looked at the spreadsheet just before I came here, and I think it's about 1,500 up to this point. So when you think of a health district with 100,000 people, 70-something thousand people in Norfolk and 40,000 people in Haldimand, that's 1%, 1.5% of the community. In some ways, just interacts with us for sexual health services that we're aware of. But we're in the background, and we don't really try to highlight that because we want people to stay healthy. I want you to, I want to discuss something that is really quite problematic. In Ontario last year, about 1,265 people died of opioid overdose deaths. Substance use, substance misuse, opioid use, and stimulant use, crystal meth, methamphetamines, is a real big problem in our society. And it's a problem in Norfolk County, and it's a problem in Haldimand County. Our local data, which isn't robust, is that of those 1,265 deaths last year, at least 10 of them were in the counties of Haldimand and Norfolk. And if you look at the data, it's just not young people, although I think that's a big part of it. It's people in their 50s as well who've had overdose or opioid-related death and toxicity. Just to put that into context, the number of people who died in motor vehicle crashes, if 1,250 people on average died of opioid deaths, so it's 341 in the province who died of car crashes. So there are more people dying of opioid deaths than of traffic fatalities. And a big part of opioid deaths and opioid use is the transmission of diseases. So people that are using intravenous opioids or intravenous drugs or injectable drugs more broadly are at risk for getting hepatitis A, hepatitis B, hepatitis C, human immunodeficiency virus. And for the most part, that's related to sharing dirty needles and paraphernalia. I'd like you to open up the next red. So if I could ask you to look at the different things that are there, if you can just empty the case. So this is, if I could share with you what is common about the syringe and this, which is what we call a cooker. This is sterile water. This is vitamin C, which is also sterile. It's really important when people who are currently using injectable substances use clean needles and clean paraphernalia. It's not because we endorse the underlying conduct. That's not the goal. The goal is to try to prevent the transmission of illness to the person who's currently using illicit substances, but also to prevent them from transmitting those illnesses to their sexual partners. And we also have this goal of trying to prevent the transmission of people that disease that had no real involvement at all. So, and if I'll explain this just a little bit more. So sterile needles mean that people don't share needles. If you don't share needles, they're less likely to transmit illness from sharing needles. This is a cooker, and you can open one up if you'd like. I'll open one up if I can get the container open. So many times when people use injectable drugs, they put the drugs in powder format or in some crystalline format, and they heat it up, and they mix it with water, and sometimes they have to mix it up with some vitamin C. The reason we give this is because if we didn't give the sterile water, or we didn't give the vitamin C, people might use whatever water is available, or ginger ale, whatever it is, and obviously that's not safe, right? That's obviously not safe. So how hard are we working at this? Well, we gave out 100,000 needles last year in the health unit. And there are probably many hundreds of people who are affected. We don't have perfect data, but we think there are probably many hundreds of people who are currently using injectable drugs. Now, how does this also affect people that perhaps have little to do with people currently using injectable drugs? Well, we know in this county that we're finding needles in places like parks and sidewalks. And so we also have a pathway where when people do use needles and they're dirty, that they can be deposited in a safe place. And these kiosks exist throughout the counties of Haldimand and Norfolk. I want you to open the third package. That's just at the bottom. So this is naloxone. This is a drug that if someone is overdosing, that you can actually reverse or try to reverse the overdose. And we distribute these kits not only to the people who are currently using opioid drugs, we also give it to their families and other people who might interact with them. Now, naloxone can be given as an injection, but it can also be given, this is a nasal format. And in nasal format, the person will be positioned properly, and all you have to do is inject it. And that might be enough to save that person at this point in time. But one thing, so these list examples talk about how we're discreet, we're confidential and strategic. If you'll also notice in this package, there's a condom, because the prevention of disease, sexually transmitted illnesses is also a risk when people are using injectable drugs. But given all of this, I hope that we have made the case that what we do is interdependent, that although we're discreet, confidential, and strategic, our plan to try to help people is interdependent, it demonstrates some interdependence. So if we could go on to the next slide, kindly. So the Public Health Service has two main functions. One is health protection, which is what I talked about just now. You know, all the things that we try to do to help people when things go wrong. And then there's health promotion, all the stuff that we try to help people hopefully live a more productive and healthy and fulfilling life. So they're really two sides of the same coin. As we go down this presentation, you're going to hear from my colleagues, Ms. Pongranz and Mr. Shaw. Ms. Pongranz leads health protection, and Mr. Shaw leads health promotion. And they'll share those two sides of the same coin. But if I could go on to this slide, just as some examples of health protection, it's procuring and distributing vaccines to family doctors, management of outbreaks of communicable diseases, inspection of restaurants for foodborne illness, inspection of tattoo parlors, hair salons, barbershops, and spas to minimize the risk of bloodborne illness. Health promotion, on the other hand, they're a group of activities that are less, perhaps not as well known, but equally important, providing smoking cessation classes, a menu of services to pregnant women and new mothers and infants, the responsible consumption of alcohol, monitoring compliance with the Smoke-Free Ontario statute. If you go to the next slide. I think this is really important. Our main goal is to support people making informed choices. And although sometimes it appears that the Public Health Service tells you what you can't do, in fact, that's far from the truth. I think, in public health, we want people to live the most fulfilling life they can. and benefit from all the advantages we have in this wonderful province. It's based on the constructs of autonomy, allowing people to make their own decisions, equality, that we try to treat everyone about the same, community, that we care for others than just ourselves, benevolence, and really important, rationality, that we make decisions based on something more than our unfounded biases. So given that, I'll talk about rationality in a minute. If it's okay, go to the next slide. There is this new construct, which is that the province has directed the medical officers of health and the Board of Health, which is all of you as board members, to engage in issues relating to health system planning, funding, and service delivery with the local health authority. That's a new mandate, and I think that's something that we can all work on to try to improve programs and services for people in the counties of Norfolk and Haldimand. Next slide.
It's my understanding, we used to have a part-time medical officer, is that correct? And now we're full-time, or could you just give us a little bit of background on that?
So the way health service, in Ontario, is a long history by statute of how health units were operated. Fundamentally, I think the law would, if following the history of the law, counties were responsible for having a medical officer of health. That predated the OHIP and government running of hospital or public funding of hospitals. It's my understanding that the statute requires every health district or every health unit to have a full-time medical officer of health. Now, I understand for a time that there was a medical officer of health shared between this health district and Brant, and Marlene can talk about it more, and maybe at the end. But at the most recent health audit, this is before I started here, that was a deficiency recognized in the audit by the Ministry of Health, and like every other provincial directive, we have to call compliance, and so that's how I think I was recruited to this position. So, so does that provide context, Board Chair?
It does. Do you know how long ago that was that change happened? It was a couple of years ago, correct?
The
From
statutory
from the-
directive.
No, from the shared
Well,
medical officer of health.
It was only 3 months. My guess, and we can check the dates, I think Dr. Locke relinquished the joint responsibilities, I believe, in March of 2018, and Dr. Urbanki worked on a part-time basis until October.
Oh, I didn't realize it was that recent. Okay, thank you.
So Malcolm Gladwell, probably a likely successor to Marshall McLuhan. We have to base our programs based on epidemiological intelligence. We have to base it on what we actually know, and that goes to the whole construct of rationality. We can't use our personal opinion to guide the programs and services. And so Malcolm Gladwell said, the key to a good decision-making is not knowledge, it's understanding. We're swimming in the former, we're desperately lacking in the latter. So with that, if you could put the next slide, Kyle. We are working really hard to develop an epidemiological intelligence, or epidemiological evidence, and to be guided by that as we move forward with programs and services. And Mr. Orenko is going to speak to that, about how we're going to try to gather data, develop knowledge, but ultimately formulate understanding so that we can guide our programs moving forward. So with that, I'm going to have my colleague follow me. For all these items, if you could put them back in the box, and we'll collect the boxes. If you would like a naloxone kit, come by our offices, and we'll find a way to get you one. But for now, the statute would require us to reclaim all these items.
Nothing by us.
All right, through the chair to the board members, my name is Chimero Koronkwo. I'm the Director for Quality Planning, Accountability and Performance. As Dr. Shankar has mentioned, the work we do has to be grounded in evidence that yes, we should work in a particular area, and evidence that the work we're doing is making a difference. And it is my role and responsibility within the division to be able to support the program staff to be able to plan their programs, implement their programs, and evaluate their programs to demonstrate that we are making a difference. So in the next few slides, I'll just demonstrate a few things we've done thus far and how our work impacts the work of my colleagues and how it helps the Board of Health meet its accountability to the ministry. In the first slide, which you already have a copy of, the first thing we do is to find out what is our community profile. In the area we are servicing within our jurisdiction, what's the population demographic, who make up the population. And that guides us as we try to plan and implement our programs. So the profile demonstrates that our population has grown by 0.6% since 2011. This profile is based off of the census in 2016. It also demonstrates to us the different age distribution. You will notice that we have over 20% of our population who are 65 and older. The males are 49% and females are 50%. So that's a profile. This is a public document. You will be able to find it on our website. It just shows you what kind of population we're working with, and it guides us as we go through our programming. There are a number of data sources that we use to be able to derive this evidence that informs our program. And I think Dr. Shankar did allude to some of them, but I'll just go through a few on my list. It's not exhaustive, but these are the ones I would like to highlight in this presentation. The first one is the IFIS, which is the Integrated Public Health Information System. So this is the system we use to report on reportable diseases. Dr. Shankar did demonstrate with chlamydia and gonorrhea. That's one example of reportable diseases. Once they are discovered, we need to report on those diseases to the province, and we need to monitor them and follow up on those diseases. So we use the database, the IFIS, to do that. The other database is called the BORN database. It's the Ontario Pregnancy, Birth and Childhood Registry and Network. We use it to report on our maternal health data. Then we have the CCHS, which is the Cross-Sectional Canadian Community Health Survey. So this is a broad survey and is done on a regular basis where we go into community and trying to find out what are those health behaviors out there, what are those health outcomes out there. And when we get this information, it helps guide us in planning our programs to respond to those health outcomes and concerns we have in the community. As I mentioned, our community profile is based off of Stats Canada, which Stats Canada's regular census. We get that from them, and we use that in getting our community profile. We also have the ISCIS, which is used basically or mainly by a program we have within the health unit that's called the Healthy Babies, Healthy Children program. I'm going to try my best to describe the program, but I'm sure my colleagues will do a better job than I would. So what this program does is that it tries to identify those families who are at risk, and when those families are identified, we follow up and ensure that we try to help them whatever barriers there are out there. So when we're delivering that program, we use this database to try and capture the information on our program implementation. Then we have the panorama, which we use for our immunization and vaccination data collection, trying to know who has been vaccinated and who is in compliance with immunization. Then we probably have another database we assess, which is IntelliHealth. This is more like a hospital-based database where we look at discharge information, we look at ambulatory care reporting system, ED visits. These things help us. You may want to ask yourself, why are we curious about what's happening in hospitals. It is critical. If we hear of so many visits, say, for falls at the emergency department, it tells us in public health that probably there is an opportunity for us to make some improvements in public health to prevent people showing up at the emergency department. Then we have the OHIS, the Oral Health Information Surveillance System. I'm sure some of you may be aware that every year, staff of the health unit go to elementary schools to screen children for dental concerns, to identify those who have dental issues. When we identify them, we would follow them up to ensure that those dental concerns are addressed. So that program uses OHIS to try and record all the information they gather through their dental surveys. Then the last and definitely not the least, we have Hedgehog, which we use for our public health inspections, where we inspect premises and we use that database to take notes of all our inspections. And those inspections from January to early this year is now public, and you can access those inspection results on our website. Now, for our new directions going forward, we are hoping this year to do a community needs assessment, where we're going to go into the community, we'll do surveys, we'll do focus groups to try and find out from the community what are those areas of priority they would like us to focus on, and working with all the different data sources and the information we get from the community. This will help us to define our direction going forward. And with that, if there are no questions, I'll hand over to my colleagues, Ms. Pongratz and Mr. Shan, to continue the rest of the presentation. Thank you very much.
So thank you, Mr. Okaranko. It really is a pleasure to be here today presenting to the Board of Health in regard to the programs and services that we provide here at the Health Unit. My name is Stephanie Pongratz, and I'm the Manager of Health Protection, and my colleague is Mr. Shaw, and he's the Manager of Health Promotion. I appreciate Dr. Anissa Thuri's analogy in regard to public health as being both health protection and health promotion, but two sides of the same coin. So if we look at health protection activities at the Health Unit, what they tend to focus on are things like ensuring safe food and water, mitigation and prevention of health hazards, healthy environments, as well as prevention and transmission of communicable diseases. This side of the coin is very regulation driven, and there's lots of mandated response times within our protocols. For instance, we have the 24/7 on-call emergency response. That's mandated within the protocols that we have. When a call comes in at 4:15 p.m. on a Friday afternoon, you can guarantee that it's our team that's jumping into action to take care of the concern for the residents of our counties. So as exciting as health protection may sound, Mr. Shaw's teams are equally as important, and I'll let my colleague explain more about health promotion.
Thank you, Ms. Pongratz. As my colleague mentioned, health protection is more like firefighting. But the other side of the coin, that is health promotion, is more about building policy and changing behaviors that take time. Health promotion moves beyond a focus on individual behavior towards a wide range of social and environmental factors. In a nutshell, health promotion is a process of enabling people to increase control over and to improve their health.
So So when we were thinking today how to present to you, we felt the best way that we could describe and highlight our services were to provide to you a story about a typical family within Norfolk County and how public health is entwined within their life. Please note that this family is fictitious as well as the characters. So if there's any coincidence to your own family, that's purely coincidental. As we tell you the story about this particular family, you'll see that either myself or my colleague will be speaking to highlight the various sides of our coin. So if we're ready, let's meet the Haldner family and find out their background to set the backdrop of our story. So here we have the Haldner family. Mom and dad live with their 3 children on a rural farm property in the Haldimand, Norfolk area. Grandma lives in a smaller house on the property. They're 3rd generation farmers, cash crops, and they employ seasonal workers. Let's meet the parents. So we have Sandy, who's our mom. She's in her mid-40s. She's a stay-at-home mom. She enjoys making homemade meals and grows her own vegetables in the garden. Robert is the dad. He's also in his mid-40s. He's a farmer, and he was a regular smoker, but quit smoking after his 2nd wife was born, and he likes to woodwork in his spare time.
So let's meet the kids. Anita, she's the oldest one. She's a post-secondary student. She's going to school to become a public health nurse, and she has read every John Green novel. Jacob is the middle one. He's in high school. He wants to take over family farm when he grows up, and he enjoys hunting and fishing. Bobby is the youngest one. He just started junior kindergarten. He wants to be an astronaut fighter when he grows up, and he likes the color yellow more than the blue because it's happier. So don't forget about grandma. Her name is Linda. She is 85 years old. She's a retired home worker, and she likes to cross-stitch while watching her shows.
Oh, and by the way, one of her favorite shows to watch